Next, Dr. Nowakowski from the Mayo Clinic will address the next questions in aggressive B-cell lymphoma.
Hello, my name is Greg Nowakowski. I'm at Mayo Clinic Rochester, and I would like to thank the organizers for invitation to this meeting. And particularly, I'm excited to speak at the session about next questions, because as you will see in a few minutes, some of the next questions will be answered relatively quickly in aggressive B-cell lymphoma. In fact, maybe we'll see some of the answers by the end of the year. But even if we see those answers, as usually it is in life, we'll see a generation of a whole bunch of new questions associated with that. And so I'll try to address this today a little bit, where the field is going and what emerging questions we may have, even if some of the immediate questions may get answered as quickly as during the ASH meeting in December. Those are my disclosures. So let's start from the current pattern of care in diffuse large B-cell lymphoma. In the first line, R-CHOP or R-CHOP-like chemotherapy cures approximately 50 to 60% of the patients. Currently, the standard approach in the second line for transplant-eligible patients will be to proceed with intensive chemotherapy and transplant salvage. Transplant non-eligible patients are considered to be largely curable, and there are candidates for a number of palliative therapies. In the third line, for patients relapsing after transplant or other therapies, CAR T cells recently became available, as well as a number of new targeted agents, including polatuzumab vedotin, tafasitamab, selinexor, and loncastuximab. So those are new agents in this space. And this is current pattern of care. So the big question is, how will this treatment landscape look in 2022? It's been stagnant in a frontline therapy for nearly 20 years. So R-CHOP is the standard therapy for 20 years in diffuse large B-cell lymphoma. And if it's a standard, it's not for the lack of trying. There are multiple studies, and we tried pretty much any possible strategy you can think of: maintenance, higher doses of antibodies, different antibodies, intensified chemotherapy, and adding new agents. We also try it in agnostic way for everybody, for patients with high-risk disease, or for patients defined as high-risk disease by molecular features like ABC or non-GCB subtype. All those efforts have failed so far. However, just recently, there was a press release that Polaris study comparing polatuzumab vedotin in combination with RCDP versus R-CHOP have shown indeed benefit in a primary endpoint of progression-free survival. So we expect that the study will be presented at ASH, and we're looking forward to it, because this indeed may affect how we think about frontline therapy in large cell lymphoma. And if you look at Polaris design, the study was designed for adult patients with large cell lymphoma, IPI 2 to 5, and randomized 1-to-1 into two treatment arms, which I just mentioned, with the endpoint of primary progression-free survival. And associated questions with this is cell of origin still important, or other molecular markers still important in frontline studies? What's the magnitude of benefit and impact on overall survival? We did not hear anything about overall survival impact in press release. And what's the impact on practice and ongoing clinical trials, which are still using R-CHOP as a control arm? And based on what we see from the press release, I think if the Polaris results are indeed looking as good as in the press release, it shifts the balance a little bit to cell of origin or molecular agnostic approaches, because this study basically targeted patients regardless of the molecular subtype of diffuse large B-cell lymphoma. Also, if there is a significant benefit in PFS, it may impact frontline practice, particularly if FDA approves this combination. However, it will be important to look at the subset analysis in this study to understand if there are some patients who specifically benefit from this therapy, particularly with high-risk disease and high IPI. Finally, if there is no overall survival difference, and we'll see the presentation at ASH, but if there is no overall survival difference, R-CHOP control may still be acceptable in already ongoing clinical trials and in the future planned clinical trials, because the issue will be what we'll be using as a new control arm in the ongoing studies and planned studies. And I think this will be largely dictated by the survival overall survival impact and the magnitude of the impact in progression-free survival, and how broadly this will be adopted in the practice if approved. So one question will be answered, and many other questions will arise, and this will likely happen later this year in the frontline studies. What about in the relapse refractory disease? Well, in a second line, there were 3 press releases. Again, we haven't seen any data of this study, those are just press releases, comparing CAR T-cell therapy to chemotherapy plus transplant in a second-line treatment of patients with relapse refractory diffuse large B-cell lymphoma. Interestingly, 2 of those studies are positive, so show the advantage in the primary endpoint of event-free survival for CAR T-cell use. And one study, reported by Novartis, the Belinda study, per report so far failed the primary endpoint, so did not show advantage to CAR T-cell strategy versus transplant. But if those strategies are moving forward indeed to the second line based on those 2 studies, obviously we have to understand the impact of the studies, the magnitude of the effect, and all the details. But let's say if they are moving forward, then the next big problem in the field becomes management of the patients who are relapsing post-CAR T-cell. And it really moves to the center stage because CAR T-cells we use much more than we use it currently. And if you look currently at the outcomes of patients with CAR T-cell therapy, about 60% of the patients will relapse. And the outcome of those patients is quite poor, with median survival of only 5.3 months. And unfortunately, many patients are not the candidates for clinical trials. One of my colleagues, Dr. Bazera, conducted this analysis when he looked at the common inclusion criteria in studies which led to accelerated approval of the ages listed here in this table. And you can see that roughly only about half of the patients at the time of relapse post-CAR T-cell therapy are eligible to the clinical trials per standard criteria. And those criteria in those studies were actually quite liberal, to give credit to the study sponsors and investigators. So how do we move forward in this setting? Because it's a group which particularly requires better therapies, because ineligible patients for the trials in his study had particularly poor outcome. And this poses this next question here: how do we develop studies and treat patients relapsing post-CAR T-cell therapy? And I think there's a need here for studies which are not excluding patients with cytopenias. So our eligibility criteria will have to change. And there's a particularly good space for development of agents which are not myelosuppressive. So not myelosuppressive strategies, immune-mediated, like bispecific antibodies, targeted therapies which are not associated with myelosuppression would be really preferred in this group of patients. And you've heard a lot at this meeting, and I'm not going to go over the details here, but bispecific antibodies, for example, could be very promising in this space, still working for engagement of the immune system and possibility of residual CAR T cells, but without necessarily causing typical myelosuppression associated with some of the other agents. Finally, we have now a number of new therapies already approved through the accelerated approval process in the relapse refractory space. And as of May this year, we had 4 of those. And they became available now in the second line in transplant-eligible patients, like Tafa-Len or other chemotherapy combinations. There are actually polatuzumab PR is also recommended by NCCN guidelines in this space. And they are definitely available in the third line, along with the CAR T cells. So how do we sequence the therapy now when we have a choice is the next big question. How do you select therapy? Because you have a choice. And if you look at this sequencing of therapy issues, they have different modalities. So there are 3 cards and 2 non-cards, but all targeting CD19. We have 2 ADCs. You have 1 antibody we'll combine with IMiD and 1 nuclear transport inhibitor. So there are different modes of action and different targets, but sometimes mode of actions or targets are overlapping. I think bone marrow transplant immunotherapy are still in the picture as well, so it adds to the number of permutations. And if you just count those 5 therapies and count the number of permutations, you can quickly come up with the number of 120, which is something which we'll never be able to test in randomized clinical trials or controlled clinical trials. And here I do believe that the real world data will aid sequencing and choice of therapy in relapsed refractory large cell lymphoma. There are a number now of prospectively designed, well-designed real-world data studies which are trying to capture this aspect of sequencing and efficacy, depending how therapies are sequenced and patients' outcomes. And those studies will ultimately answer this question: what therapy to choose in patients who are not eligible for some of the clinical trials are more of escalated approaches. So the sequencing of therapy is a big question, but it will take some time to resolve. So this was my last slide, and thank you very much for your attention.